So I'm Morgan Barnum. I'm one of the OBGYNs that practices here at Hudson Physicians. And I've got three partners, OBGYN partners, who also would be capable to see you for any of these issues as well. So I'm just going to kind of talk on behalf of our group about pelvic organ prolapse and incontinence. The talk really, the reason I call it pelvic organ prolapse is because this really is a huge multitude of problems that involves the pelvic floor. One of those problems being incontinence, but there are several other issues like pelvic organ prolapse that happen with or without incontinence, and so that's why I wanted to kind of broaden the scope of that just a little bit. Alex is with us as well, and she's one of the physical therapists down at River Falls Hospital, and I've sent her many, many patients over the years for pelvic floor physical therapy. She's very skilled, and she'll talk with you about kind of how she evaluates patients and some further information at the end of my talk as well. So it's interesting when Michelle has done such a great job coming up with a speaker series, and I think patients love this. I mean, it's nice to come and get information about something you may or may not know things about, you might experience. You may not know if you're experiencing them. But one of the topics that she brought up was actually pelvic floor prolapse or incontinence. And she said, you know, it's interesting because you never really hear physicians talk about this. This isn't something that's a popular topic to talk about. And I said, well, boy, it's a popular topic in my office. We talk about it all the time. But I think what happens is, especially from an OBGYN standpoint, we kind of like to be fixers, right? That's part of what we do in medicine is we take a problem, we have some intervention, and we hope to have a good outcome on the other side. And I'll use heavy menstrual bleeding as an example, right? We have a lot of people come into our office and talk about heavy menstrual bleeding. We have an intervention, and usually we fix that fairly simply on the other side. The pelvic floor is a lot more complicated than that. Historically, we've kind of talked about it as far as being a bowl, if you think about that area of the body. So this is what we're talking about when we're talking about the pelvic floor. Sorry, I'm gonna act like I have a pointer, but the pointer's not working. So forgive me for that. But this area is what we're referring to when we're talking about the pelvic floor. And a lot of times people don't really understand this anatomy. When I was learning this in school, we really always talked about that. The pelvic floor is a bowl. Well, what's sitting in that bowl is your bladder and your bowel and your uterus and your ovaries and your fallopian tubes. But I really like to think about it more as like a basket, right? So if you think about a woven basket, that's really kind of what you're looking for. And if you put something in it that's a little too heavy, or you push something against it that's a little too awkward, you start seeing that those fibers start to break down just a little bit. And the same thing can happen in the pelvic floor. And when that starts to happen, you can imagine why things like the bladder, the vagina with the cervix and the uterus, and the bowel can start to kind of sag down in through the fibers of that basket. So we can see a whole host of problems that occur when that starts to happen. So what are we talking about when we talk about pelvic organ prolapse? We talk about descent of one or more aspects of the vagina and the uterus. We talk about the anterior wall, the posterior wall, the uterus, or the vaginal apex. So this is areas that we may be dealing with. This is the anterior wall or the front wall, and that's what shares a wall with the bladder. The posterior wall or back wall, and that's what shares a wall with a bowel. The vaginal apex is kind of way at the top of this. If for some reason the uterus had already been taken out, that's called your vaginal cuff or the vaginal apex, or your cervix and your uterus. And any of those can prolapse. And I like to say prolapse is kind of like a hernia. You know, people talk about hernias all the time of the anterior wall, right, where there's a weakening and things don't quite work the way that they're supposed to, that you can have that bowel that kind of pushes through the anterior wall. We talk about this a lot less, right? This is not something that we're telling our friends about, and hopefully we are today, and that's why you guys are all here, but something I feel like we need more education. So who, what, and why? So one of the things that I think is a misconception is that this is a certain subset of people that actually have to deal with this. But you can actually look around the room. You see the ages span. And so I think that's a big misconception, is that you get to a certain point in your life and you have to deal with this, and that's when you just move on, and that's part of the aging process. And I'm here to say that's not the case. And at any point in your life, if you experience this, there are things that we can do about that. So 3% of U.S. women report symptoms of a vaginal bulge. 41 to 50% of women examined by their providers exhibit prolapse on exam. So that's really interesting, because if we're not talking about it and there's not an awareness of it, things may feel different down there to us, but we don't really know why. You go in and see your healthcare provider and they say, by the way, do you know that your cervix is sticking out of your vagina and it's supposed to be on the inside? Or do you know your bladder is sticking out through your vagina and that's not where it's supposed to be? And so a lot of this discrepancy we really see, and we're just uninformed. We really didn't know how things were supposed to be down there. So what are risk factors? We talk about number one a lot, right? You have these big babies, you have a 10-pound baby and everybody goes, oh, right? We know what that means in the future. But there's a lot of other things that are risk factors for that. Vaginal deliveries for sure, but I have several people in my practice that have had all C-sections and they still end up with prolapse. I have plenty of patients in my practice that have prolapse that have never had children before. Age is another one. We certainly do see this increase as we age. There's no question about that, and there's some reasons for that. We spend more time upright. We spend more time doing heavy lifting as time goes on, and we see a significant change once hormones change when we go through menopause. Obesity, again, is a risk factor just because we're carrying more weight on that bowl or on that pelvis or basket, if you will. Connective tissue disorders, menopause, and chronic constipation. So anything that's going to make you have to push against that, we call it Valsalva, but kind of pushing or bearing down against that pelvic floor. A chronic cough, so you might see this more in asthmatics or smokers. We talked about this. I did a podcast right before this, and one of the examples that I used is people with inflammatory bowel disease. So my young gals who have Crohn's disease or inflammatory bowel disease, who may be in the bathroom a lot of times, will kind of weaken their pelvic floor as time goes on. The what? So most women have symptoms of multiple compartments, actually. So some people come in with very straightforward, they describe their symptoms to me and I can tell them exactly what it is. But that's not where most people fall. Most people definitely fall into this multiple compartments. Now, those compartments are the anterior vaginal wall, the posterior vaginal wall, the uterus, or the vaginal apex. So that's what I'm talking about when I talk about components. Or compartments, excuse me. So nearby organs is really what creates the problem. The bladder, again, can kind of bulge, and what you see with those types of symptoms are that instead of being well supported as it is in this picture, you actually start seeing it kind of fold in half. So you might be emptying part of your bladder, but you're not emptying it the rest of the way. Now all of a sudden, you think you went to the bathroom, you think you've emptied your bladder, and you lean forward. So now you're changing the anatomy of how this sits, and all of a sudden you leak urine. Well, that might be from pure incontinence, but that actually might be from prolapse. And so that's really where kind of getting to the bottom of what's going on in the system is super helpful. The same thing can happen with your bowel. So people will come in and complain about, I have a bowel movement, and it may be hard to get out. I'm not really constipated. It's not the little rabbit pellets, but I just feel like I physically can't get the stool out. And then I go, and it may be a little while later, and I feel like I have to go again. And that's kind of the same thing. The anatomy has changed in that area once, instead of being that picture, that well-supported vaginal wall, you actually start to see that sag down a little bit, and it changes the way that stool has to come out through the rectum. So it's always been amazing to me how many women discover splinting. So I'll describe this. We don't need a show of hands of any of this. But a lot of women will discover that because that back side of the vaginal wall is not supported the way it should be, that they actually will put 2 fingers into the vagina to essentially create support and push against it, and then they can evacuate their bowels without problem. And several women discover this just on their own. It's like somehow I have to physically get that out of there, and I don't otherwise know what to do. So that's called splinting. And so that's something occasionally people will come in and complain about. This is just semantics, really, but kind of an interesting point. So most women will start feeling symptoms when the leading edge of whatever the prolapse is about a half a centimeter into the vagina. So it's about this far. So that's a decent amount of prolapse that somebody will experience before they start having symptoms, at least that they recognize as being symptoms. So really, if you go into your nurse practitioner, your OBGYN, your primary care doctor, and you happen to have your routine annual physical exam, and for some reason you have a pelvic exam done that day, and they say, did you know you have prolapse? And you said, no. What is prolapse? What would I be looking for? And if you have none of those symptoms and things don't bother you, it doesn't matter. It's fine. You can go about your way and you don't have to do anything about it. This is not a problem that you're going to be unaware of. One of the things that will occasionally start happening, though, is you start coming in and complaining of other things, like recurrent urinary tract infections. That's a really common one that we'll see, where people don't necessarily feel a bulge. They don't necessarily feel like they have prolapse, but when I look back at their chart, I can see that they've had 6 positive urine cultures in the last year. Well, I already start thinking she's probably not emptying her bladder, and that bacteria is able to build up inside the bladder. And so that's where, I mean, I fit a 100-year-old patient of mine the other day for a pessary because of that reason in particular. And so there are lots of times where we say, okay, you might not necessarily know you have the symptoms, but now it is actually physically affecting your health, and we've got to do something about it. One of the other things that I know is on the Facebook page, and definitely is an issue that people a lot of times feel embarrassed about and don't really talk about it unless there's prompting, but things like leaking urine during intercourse or feeling like their partner is running into something when they're having intercourse and they feel really embarrassed about it and they want to totally give that up because it's like, oh, I feel uncomfortable, I feel self-conscious, all of those types of things, and we can start seeing that as well. So this is kind of the anatomy, and we don't have to go into this a ton besides, I think this is an interesting angle when you think about what I talked about at the beginning, which is the pelvis is kind of like a bowl or like a basket. And you see all these muscle fibers, and as those muscle fibers start to weaken, you can see how the support structures for the pelvic floor can start to break down a little bit. So this is kind of looking at the pelvis from this direction down. Here's another view of the anatomy from the side. And again, kind of understanding where, if all of a sudden, so here's your bladder. Here, this is where my height is not super helpful at not having a pointer, so bear with me here a little bit. But so bladder, urethra, and if all of a sudden this has tipped all the way down, you can see where that change is not super helpful at being able to actually fully evaluate or empty your bladder, and where you might see those problems come up. The same thing happens here, and you actually will see this thin little sliver here is the vagina. So if all of a sudden this tissue, which is this white fascial tissue, that's the support structure, has weakened or gotten a hole in it as time's gone on, now all of a sudden that bowel can kind of bulge into the vagina, and that's where people have a hard time getting the stool to empty. The same thing starts to happen with, support structures around the urethra as they start to break down and we start to lose some of the support for that bladder neck angle changes, and we can, we cough, laugh, or sneeze, we put that increased pressure, and now all of a sudden it's a straight shot out. So where all of a sudden it's like trampoline parks, no thank you, right? So you can kind of understand that anatomy a little bit more. And I put the anatomy in here because I also talk to women all the time, and people just don't know the anatomy of their pelvis. And it's really common. People are embarrassed to even talk about that. But why would you guys know this, right? If it's not something that we're talking about. And so I have a lot of people who have that question, okay, well, wait a minute. Do I still have a cervix if I had a hysterectomy? Or do I still have my ovaries? A lot of people, get confused about that piece of it. So it's kind of helpful to actually visualize the anatomy. As far as treatment options go, what do you do about this? Okay, so now you suspect, based on your symptoms that you have, that you may have some variety of pelvic organ prolapse or incontinence that you want to talk to your provider about. Usually the first thing I say is write your symptoms down. It's actually super helpful to have thought about this information, know what the symptoms are, know when you seem to notice them more often. Because I get a lot of like, okay, well, I'm just going to go in and see somebody. I'm going to take the plunge and go in and talk to somebody about this. And now I'm there and I start asking questions like, does anything make this better or worse? Do you notice that if you've just emptied your bladder, you could sit down on the toilet and go to the bathroom again? Do you notice, as Alex will talk about, I get into a store and I feel like I have to go to the bathroom automatically? Are there certain activities that you do, like if I have intercourse and I haven't gone to the bathroom beforehand, then I might leak during the middle of intercourse? Do you feel like you always have battled with constipation regardless of taking fiber and Miralax and increasing your fluid consumption and all of those types of things? Do you feel like there's a bulge in the vagina? Okay? So jotting some of those things down and doing the prep work before you come in for your visit is actually super helpful for you, because I'm going to be able to glean likely what the problem is by a good detailed history. And the problem is, when this is a foreign world to us, it's one thing if you go in and you say, my knee hurts when I run, right? That's a little bit more straightforward. This isn't quite that way. So I say, write down what your symptoms are. If you can track it ideally over a month or so, that's probably going to give us a really good basket of information. And then the second part, you come in and you go through this history with your provider. We'll look at medications. You know, did anything change? Like, yeah, actually, I started this new blood pressure medication. Well, is it a diuretic? Well, I don't think so. I'm not sure. But a lot of blood pressure medications will have a small diuretic in them, and that can contribute to it. Or I started a new antidepressant, and there are actually some side effects of this that can create that. So we'll go through all of that with you, and then we do your exam. And I think a lot of times what people think about with this, and where a lot of people are afraid to even come in, is we've heard all this bad stuff about mesh, right? So people say, well, if I have prolapse, you're going to have to put a piece of mesh in, and I know how bad that is, and I don't even want to go there, right? We actually used to do these surgeries with mesh pretty much primarily. So what we would do is this wall that's kind of weakened between the vaginal canal and the rectum, or the vaginal canal and the bladder, we would actually slide a thin piece of mesh in and kind of tack it up in 4 spots to recreate that firmer tissue, just like they would with a hernia, because that's how they fix most hernias, okay? Unfortunately, because we talked about menopause being an issue, if this tissue gets too thin, like sometimes it can with menopause, you may start getting some mesh erosion in that area. And that's really, that change happened, a decade or so ago, where we really tried to avoid using mesh for pelvic organ prolapse surgeries. So there's one situation that most OBGYNs are still going to recommend using a piece of mesh, and that's with just a sling. So that's for stress urinary incontinence, and we kind of talk about that in a minute. But for pelvic organ prolapse, we really are doing a primary repair, meaning using your own tissue in almost all cases. Sometimes if you need a redo surgery, we'll talk about using a piece of mesh, but that's fairly few and far between. So what we do is on the sides of, again, this is the vaginal area here. On the sides of this anatomy, you actually can find good tissue. So it's kind of split in the middle, and that's where that hernia has come from. So what we do is open the top of that and find good natural tissue from you and close it over the top of where that defect is. So there's not mesh that's involved with most of this surgery. If somebody comes in and they have terrible prolapse and they've been a longtime smoker, they've had to use chronic steroids for a long time, I know the quality of their tissue might not be quite as good, and those may be people right from the get-go that we would consider using a piece of mesh. But for most of our patients, we're pretty comfortable doing this without. Now with the sling, fortunately, if you come in and you just really are experiencing pure, what I call stress urinary incontinence, so that's, I only leak if I cough, laugh, or sneeze, if I jump on the trampoline, if I kind of do those types of things. then we typically, if we're doing something surgical, we'll use a piece of mesh with that. And fortunately, we will use a little bit of vaginal estrogen because you can get mesh erosion with the slings as well. It's just usually less of an issue because it's such a small piece of mesh. But there are lots of other alternatives than surgery, right? I'm here and I'm the one who does these surgeries, but I try all sorts of other things before I take people to the operating room for their pelvic organ prolapse or incontinence. So we usually do some lifestyle modification first, right? So if you are on medications that are making you actually constipated and you haven't tried increasing fluids and you haven't tried fiber, then I'm going to try those things first to see if we can actually get your bowels moving easier. And maybe the prolapse is not as big of an issue as we initially thought. Maybe you have, the nurses like to talk about that, but maybe you have nurse's bladder, right? Where the nurses don't ever go to the bathroom. They're working a 12-hour shift and drinking plenty of liquids, and they don't ever stop to pee. So there's kind of always this joke that they could hold, a liter of urine in their bladder. Well, if you have such a big bladder capacity, it may just take some bladder retraining where we say just don't walk around with that much urine in your bladder and you might be okay. So there's lots of lifestyle modifications, again, that we can talk about. If you're drinking caffeine in the evening time or you're having a second or third glass of wine before you go to bed, maybe we stop those things and you might not be waking up and going to the bathroom all night, okay? So there are plenty of lifestyle modifications that we can talk through. And depending on what your problem is, some of them help and some of them don't. There's something called a pessary, and I actually manage a lot of pessaries in my clinic. And so I don't know if anybody ever used a diaphragm for birth control in the past, but they're kind of like a diaphragm. So they come in all shapes and sizes. The most standard pessary that we use is kind of a round ring that's kind of a rubbery silicone type material. It folds very easily, and we can just put that in the vagina. And what that does is it now pushes out against that sidewall on both the anterior aspect and the posterior aspect and kind of acts like there's something there. It acts like there might be a piece of mesh or that we've fixed that area. And I have a lot of people that are super satisfied with this. And I do that in certain populations of people, either people that say, I have no interest in going to the operating room. I don't want to have surgery. I'm not a good candidate for surgery. I am not done having children. So that's another really common one, and I think a misconception that people have. A lot of times people really battle with prolapse in between their kids. And of course, I'm not going to operate on that area if I don't have to during that time period. So I have a lot of people who say, I really am not bothered by my prolapse unless I'm running. So they put a pessary in when they run, and they don't do anything in between. And then we can talk about things like Kegel balls. So Kegel balls is kind of a nice intermediate between doing pelvic floor physical therapy with a physical therapist and having surgery for stress urinary incontinence. It's something that you can do at home. Kegel exercises can be hard because, again, when you look at the number of muscles in the pelvic floor, to know which ones you're supposed to be tightening can be really tricky. Alex has got a couple really good tricks about that, so I'll leave that to her. But a lot of times people are doing a Kegel exercise and they're squeezing their butt cheeks together, right? And that's probably not going to do a whole heck of a lot. So those Kegel balls will really direct us to the right area in the pelvis to try to strengthen that so we don't have that urinary leakage. And then we get into pelvic floor physical therapy. And Alex will talk about that a little bit more, but it's becoming hugely popular. And I think it really has taken off when we've stopped doing all of this surgery on that area, because that for a long time, if you wanted something fixed, you had a pessary or you had surgery. And that was kind of it. And now we really have these physical therapists who take a special interest in the pelvic floor because it's a complex area for muscle. And that's really, they hone their skills in that. So there's lots of improvement that can be had with that pelvic floor physical therapy. And then, of course, there's surgical options. So surgical options and dealing with the bladder part of it, we talk about what's called an anterior colporrhaphy or cystocele repair, bladder tacking, people will occasionally call it. We do the same thing on the back side, which is called a rectocele or posterior colporrhaphy. We will do the support of the top of the vagina is either with or without hysterectomy. So some people have it and need it at the time of hysterectomy. Some people, their uterus is fairly well suspended, and so they can keep their uterus in place. So there's lots of different options from a surgical standpoint that we talk about. So that's kind of the long and short of types of problems that you might be seeing in the area. the anatomy of why that happens, and an overview of treatment options for what you can do. So I hope that part of it was helpful for you. Again, I'll open the floor to some questions in the meantime. Understand that each of you in this room, including myself, we have a different makeup of our pelvic floor, and so how things function is going to be really different. And that's why I just encourage you to talk with your provider if you have any questions or concerns about this, and just want to know what your options are and whether that would affect your symptoms or not. Questions about that?
Have you ever had anyone come in that had a pessary that now wants to have the operation so she doesn't have to keep coming?
Absolutely. I do it all the time. I will use pessary sometimes as a trial. So I have somebody who comes in who says, I really think this is where these symptoms are coming from. I say, okay, well, let's try some lifestyle modification, see if that can help. Comes back, it's like, well, it's still there. I don't really want to go through and have surgery if I don't need to, if it's not going to fix what the problem is. And I say, let's put a pessary in and try it. You come back and see me in a couple months and see if your symptoms are better, and then you can make a decision about surgery. And I have a lot of people. I have a gal who I just operated on who had a pessary for a couple of years. She was otherwise happy with it. It was helping her symptoms, but she just flat out was done dealing with it. So absolutely, it's a very reasonable option.
How do you deal with a pessary?
The pessary? Well, there's two ways. Really, either I can deal with it, so you come in, you and I become really close friends, right? And so depending on how you do, sometimes I see people as frequent as every month. If they tend to kind of recur with infection, and surprisingly, most people do really well and don't. I like the frequency of about every 2 months. I have a lot of my patients that push me to 3, but you do start getting a decent amount more discharge by that stage of the game. So that's if I'm managing it. So I put it in, I fit it for you, and you go home and you just go about your life as you normally would, and then you come back and see me in a couple months. I take it out, I inspect the vagina, I clean it and put it back in for you, and I see you back in another couple months. So that's option one, and that's what I have a lot of patients do. They just feel more comfortable with me managing them. The alternative is that patients can do it at home, where I have a set of instructions on cleaning. It's pretty simple. You use kind of a antibacterial soap on it. People take it in and out when they're sexually active. So I have a lot of people who put it in, leave it in. Maybe they use it for exercise. Maybe they use it when they're busy, but on the weekends they don't. And they can pull it in and out as frequent as they want. And most people who have it at home usually will wash it about every week to 2 weeks, kind of depending on their symptoms. You had a question?
Okay. The one thing you didn't mention, and my doctor didn't mention, is that the body does have a discharge sometimes.
Absolutely it does. Absolutely.
Well, I think people have to be aware of that.
Oh, sure. So
it just isn't in there and you forget about it.
Yeah, so so when you're talking specifically about the pessary maintenance, right?
Right.
And that's where we talk about the frequency, and everybody's a little different as far as how much discharge they naturally produce. So some people come in and they are heavy discharge producers, and those folks, just because again that's not coming out, it's kind of held back behind, occasionally can be a breeding ground for infection. And so I do have certain people that are heavy discharge producers that I say, I really need to probably see you at least every month. I have other people that I see at 3 or 4 months and their pessary is pretty clean and they're just not producing a ton of discharge. I could give a whole lecture on discharge, and actually it's one of the reasons why the American College of Obstetricians and Gynecologists recommend that your first visit with a gynecologist is at 14. Not because you need a pelvic exam, but just for education. Because we really see things like discharge. People don't understand what's normal and what's not normal. And so that's something that I usually do try to talk to patients about, what you should look at as far as your natural discharge and what's abnormal. So we always talk about that with pessaries for sure. Good question.
Yep. I have a loved one who's older with MS, and obviously, like, she just can't, she doesn't even like to be far away. Is something like this helpful when it's MS, or is that like a whole another?
Yeah, absolutely. I have all sorts of patients with secondary chronic medical problems that result in this or make this all worse. And something like a pessary would be hugely So I would absolutely encourage her to go in and be seen, and I think there's a lot of things that people can do. Again, that's one of those things where we were talking about this on the podcast earlier. So many people feel like they just have to deal with this stuff, right? It's just like, well, I mean, I'm a woman. I guess this is something that I'm meant to deal with. And there are lots of things that we can do about that, just like any other health system in the body. Go ahead.
Yes, I don't even know how to ask this question. Is
Sure.
there a scale of how to know how much prolapse you have if the bladder is actually falling through the vagina?
Yep. So I apologize, but those are on my missing slides. It's a great question. It's really how we talk about, it really is a scale, and there's a couple of them that we use, but it's about severity. So we kind of grade them on a scale of 1 to 4, 4 being that things are totally outside the body. You can see what's called complete prosendentia, where the entire uterus and cervix has kind of pulled everything to the outside of the body. That tissue can get ulcerated because, again, that's tissue that's meant to be on the inside, and so if you're sitting on it, it will get it gets eroded or broken down. You can get ulcerations on it, those types of things too. So that's kind of the most severe form. The grade 2 to 3 is typically where we'll start seeing people come in for some sort of correction. And a lot of times I'll report a grade 2, so I put a speculum in the vagina, and I see a degree of prolapse that I think might be problematic. And then I have somebody bear down for me and have them give a big cough or laugh or something like that and see how much more that pelvic floor moves. A lot of times with that increased pressure, you're going to get your grade 2s to a grade 3 with that. So, yep, there is a system we follow. But the reality is I have patients with grade 3 prolapse that have no problems. I just see it on exam, and I say, well, no, it's there. Know that you might have symptoms. And I have people with grade 1 to 2 that have significant symptoms with it. And so from a surgical standpoint, it's helpful to kind of take note of where the anatomy is. But we really do try to make decisions based on the patient's comfort with this type of thing. Great question.
So you can have sex with these in?
The pessaries I recommend taking out for intercourse. It just would not be comfortable. So typically my patients that are managing those at home are able to just pull them out before intercourse. Most of the time the patients that I'm managing their pessaries for them, where they're coming into the clinic every couple of months, aren't sexually active. It's really not that hard to take them out at home. So if somebody is sexually active, most of the time, if people are sexually active and are having me manage their pessary, they're just nervous about doing it. So I try to have them, we've got a nice room in clinic that's got a bathroom, so I actually try to have them do it in the room when I'm just kind of have my back turned to say, well, try it, and don't worry if it gets stuck, I'm right here. And usually once I can go through that with people, that people are comfortable doing that on their own.
Getting contacts.
Yeah, like getting that, there you go. It's the same shape as a contact.
I'm going to use that in my clinic.
Yeah, I know too, yeah.
Exactly, yeah.
I just had a little bit of pessary because I didn't know what you were talking
Yep.
about. And Poise Incontinence Bladder Support showed up. Have you recommended those? I've seen those in the store.
No, I haven't, and you might have. I mean, I just don't tend to use those types of things, but I would be curious to see if you have any feedback on it.
The Imprezas, is that what you're talking about?
It's probably the same
it's not
type
the
of
same
thing.
thing as a pessary.
Yeah, so what she's talking about, there's the Poison Impreza, they insert just like a tampon, and so it's very similar to a pessary. And so my runners who have like a big race coming up, they'll use it just for that. You know, if they can manage it in between, but they're going to be going longer distances and they can't maintain it, they'll wear it, because as it inserts the vaginal canal, it expands, and then it'll push on that front and back wall and just give you that support.
Kind of does the same thing.
Yeah, and then you take it out when you're done. It isn't as dry as pulling out a dry tampon, that real painful kind of scratchy feeling, but it is still not super comfortable. But it's definitely an option, and sometimes people will use that, if we're kind of like, well, I don't know if I want to do a pessary, then I'll tell them about those, and then they use them, and they're like, that's amazing. I'm like, maybe it's time we think about a pessary. So.
Well, and I think brings up a really good point. So there are all sorts of things that you can find online. So even like the Kegel balls that we talked about, I actually have a handout in clinic, and it doesn't, I mean, you just order them on Amazon, but there are a couple of brands that we've kind of vetted as being a little bit probably decreased chance for infection and some of those types of things. Because this, with the goop era, right, so there is all sorts of things on using like vaginal weights and eggs and all of these things that I see, and I'm like, don't just buy stuff offline and put it in your vagina. Right? This is a public service announcement. Because there are all sorts of products that pop up, and unfortunately, they increase chance for infection certain times. Because some of the products, actually, there was a, I don't know what I don't even know. I don't know. I had a patient bring in a whole bag of stuff to show me one day, and I'm like, don't put any of that in there because it's like porous, right? So I'm like, that would just see. I mean, it's like the old IUDs, right? That was what the problem was with IUDs in the 70s, is that they were a nidus for infection, and so that started making. So I don't think that Poise is going to put something out like that, but that's kind of one of those things. Like, if you find something like that, just go and vet it out with your doc first and see if that's something reasonable. But
Okay, kind of a dumb question.
Nope.
Probably not dumb.
Not such a thing.
So is any of this, aside from the fact that I have to pee all the time,
Mhm.
but is it hereditary?
Yes.
Is this-
Good question. That's another question I typically ask my patients when they come in. Do your sisters or mom have similar types of conditions? Because there definitely is a genetic component to this. A lot of times the answer is, I don't know, my mom never talks to me about any of this stuff, right? Because again, we weren't talking about it, right? It was, I mean, until now, this is not a topic that was being discussed. There wasn't a whole group of women sitting around, and it's heartbreaking. I'm so glad we are now, but you'll be able to talk with your, next generation of kids, as we all will, right? So yeah, definitely a genetic component. A lot of times not for the first visit, but I do have people that come back because they feel like it's so helpful when I say things like, I validate their feelings that they're having in the bedroom about discomforts with intercourse or embarrassments with intercourse, and they usually say, I should bring my husband in here the next time. And I'm like, bring him in.
So I'm Alex, I'm a physical therapist, and I work out of Courage Kenny down in River Falls. We're an hospital-based outpatient clinic that operates right within the hospital. So if you're familiar with where the wellness center is attached to the hospital, we have a physical therapy clinic there. And I separate my time 50% inpatient, meaning people who are in the hospital for whatever reason, and then 50% outpatient. And I've really kind of honed in my special interest on pelvic floor. So a little bit about me. I did my undergrad at Iowa State University. That was a 4-year bachelor's degree, and then a 3-year doctorate at WashU in St. Louis at their medical school. And then I moved up here. I've been up here 7 years, which is crazy to think about. I got married, and then I had these 2 beautiful little girls, which have made me really appreciate pelvic floor therapy even more. So they are just darling. Okay, so what is pelvic floor rehab? So pelvic floor rehab is a non-surgical approach to address your bladder, bowel, pelvic pain, abdominal pain, any concerns that you might be having. We think of the pelvic floor as a hammock, and so kind of like she was talking, like the fibers of the pelvic floor muscles, we go to the idea of a hammock. So if your hammock isn't tacked to the trees properly, you're going to be falling out of it, or if the fibers get worn, you can slip your hand through it. We think that's kind of when those organs can kind of start to come down through the pelvic floor. And they're not really coming through the muscle belly per se, it's more of the opening that it creates. And we'll kind of get there here in a second. So the pelvic floor, here's kind of a bigger picture here. So this would be if you're laying on your back, looking right at your muscles. So it's a layer, there's 3 layers of pelvic floor muscles. So if you lay right on your back, you take your skin off, you're right at the muscles here. They extend from your pubic bone, so right in the front, all the way back to your tailbone. So we kind of talk about tailbone injuries leading to some of these concerns too. And then sit bone to sit bone, so those bony bones on the chair, and all of those together create that bowl that she was talking about. A little bit of anatomy. Your abdominals come down and attach right here, and then your inner thighs come and attach right under here. Sorry, over here. So they don't have, your inner thighs don't have a direct attachment onto these muscles, but they give a good signal to your pelvic floor muscles, which is why you see people of all ages cross their legs when they have to pee, because they don't have that pelvic floor support through here. So it helps kind of squeeze everything together to give you one last hope of making it to the bathroom in time. And then we come back here, your spine comes up here to your head. You have a bunch of muscles that come down, attach through various places, but big ones that come down and attach on either side of your pelvis too. So those muscles are important because it controls how your pelvis moves when you're walking, running, moving around, that kind of stuff. So I am typically seeing a lot of patients who come in, they have like unrelenting hip pain, unrelenting back pain, groin pain, all that kind of stuff, and my fellow clinicians are like, I have no idea. Take a peek and ask them 2 questions, and they're like, oh my gosh, yes, I am not continent, and I have all these other concerns. So we can kind of see why the back, people are like, oh yeah, my back aches, but it has nothing to do with down here. Well, it does, because if those aren't controlling how this moves, then everything down here also gets affected as well. So we have the first layer back here, right along the bones here. This layer is most affected when you have episiotomies or tearing during childbirth. So those can happen in any different directions. When they do the stitching, sometimes it can go down through the muscles. There's different grades of tearing that you can get. And so if you had stitching and that stitching was never kind of relaxed out afterwards, after you had your baby, it can get really tight too, and that can create pain in sitting. So kind of pain right here, your perineum between your vaginal opening and your rectum. And that too, when I'm getting a little ahead of myself here, but when you go to have a bowel movement, if this is kind of sucked up, if I was holding my shirt down, I'm going to go raise my arm up. If I am too restricted through here due to kind of old scar tissue, then that isn't going to move properly during your bowel movements either. Also can affect how the urination, because it forms a figure 8 right through here. And so if we're tight down here, everything up here is also going to be affected and might not be able to squeeze properly to kink off the hose, if you will. Second layer is right where your urethra is. So anatomically speaking, your clitoris is up top, and then your urethra where the urine comes out, and then the vaginal opening, and then your rectum. So the second layer is around your urethra, and that muscle can get kind of tight too, and if that muscle gets tight, it can make you have urinary urgency as well. So that feeling like you have to go pee every 15, 20, 30 minutes, an hour. We'll get more into what normal is here in a little bit. And then your third layer are these deep layers. So that's where all those organs are sitting, the babies are sitting. These tend to be the muscles that are most painful if you have pain with intercourse. With deeper penetration, that's kind of where the penis is touching, and so if you kind of feel like you're getting blocked or hit or it's hurting, those muscles can get tight too. And you can get trigger points in any of these muscles just like you can in your shoulders. And so we can work those out. I don't have a slide for this, but this has been something that's been really interesting to me lately, is in relation to bladder control. So kind of back to your abdominals. When you have any kind of abdominal surgery, particularly with C-sections, you have a cut kind of right above your bladder to get to the baby, into the uterus. And the same idea with the scar tissue is that there's more kind of research being done about that scar tissue, again, kind of adhering onto the bladder wall. And so when your bladder goes to fill and empty, if it's being restricted from any scar tissue from a C-section or an abdominal surgery, some people have like abdominal surgeries from their belly button down to their pubic bone, all of that can kind of hold the bladder up and then you can't empty it out all the way too. Which I'm seeing more and more with my frequent urinary tract infection people too, because the bladder can't contract all the way, so. Super interesting, I could talk all day. Okay, so I also want to focus too with pelvic floor therapy. So I treat men and women. So men and women, all of what we're going to talk about is considered normal. There are also pediatric physical therapists. I'm not trained in that department. But I do treat bowel, bladder, pelvic pain, all of that. But today we're just talking about bladder control. So if you have other questions about that, we can talk at the end. Okay, so what is a Kegel? So a Kegel is your ability to contract your pelvic floor muscles properly without squeezing your buttocks, your inner thigh, and all that kind of stuff. So everyone put your feet on the floor. So I like to think of the pelvic floor as a jellyfish. So if you're familiar with how jellyfish swim, they kind of float, and then something comes along and they squeeze. So you want to think of your pelvic floor, it's just kind of sitting there, and then you're going to squeeze it gently towards your head. It's not like a rocket. It's not going to take off. It's a very elegant muscle that just kind of squeezes up. So you're going to squeeze towards your head. So think like you have a pea right at that vaginal opening, like a green pea, and you're just picking it up. And if you can see your neighbor bouncing next to you, let them know they're doing it wrong. So you don't want to be squeezing your butt cheeks. You don't want to be squeezing your inner thigh. You don't want to be contracting through your core. you really should just be able to feel that contraction. Think right between your sit bones too. You're just getting a little bit of a squeeze right through there. If you can't feel it, I know someone who can help you. Am I missing anything there? Okay, so keep practicing those throughout, and we'll get to more specifics on those here in a second. So myths, kind of talked about these before, but the myths are, I had a baby, I should leak. I'm aging, I should leak. I have all these other issues, I should leak. All of those are completely false. So as you age, it is absolutely possible to get continent again. So never let you think that, oh, I'm too old to get fixed. That is not true. So how the normal bladder functions. So normal bladder functions, you sit on the toilet, your brain tells your pelvic floor muscles relax, everything relaxes, bladder contracts. Think of the bladder as like a balloon. So the balloon, the little knot at the bottom comes undone, your urine comes out, your bladder says I'm empty, your brain says cool, the pelvic floor muscles contract, your bladder relaxes, and you can move on with your day. A normal healthy bladder, you should be able to hold your bladder for 3 to 4 hours. So if you're going every 30 minutes to an hour, then we'll talk about time toileting techniques here in a little bit. I was going to stop by Starbucks, but my kiddos held me up. But a 16-ounce, so a grande size of Starbucks, so a medium Starbucks, that's how much bladder capacity is considered normal. Also, like a 2-cup Pyrex thing for baking. Next time you're at home, fill that with water, 2 cups of water, same amount of water or urine. So quite a bit when you really think about how much fluid that you actually have in there. Waking up at night, normal is 0 to 1 time a night. If you're waking up more frequently than that, it could be other conditions. But kind of like Dr. Barnum was saying, making sure you're doing more fluid intake earlier in the day versus later in the day. A lot of people, you get to dinner time and you're like, shoot, I haven't had anything to drink. So you're like chugging water because you're so parched, and then you're up all night. If you are having problems waking up frequently at night, what I tell people too is stop drinking like 2 hours before bedtime, or only drink to quench your thirst, or lay on your back and get your feet propped up. Like if you know you have leg swelling, then lay on your back, get your feet propped up, because your heart and your kidneys function better when you're laying on your back. And so then you can kind of get one more good urine output before you go to bed for the night. So different diagnoses related to bladder and your pelvic floor. I love this up here. We can finally leave for our trip now that I know where every public bathroom is. So this is a very common thing. People will only go out with their friends to a certain restaurant because they know where it is, or they want to sit at a certain table, et cetera, et cetera. So different types of incontinence. You can have urinary incontinence or fecal incontinence. Stress incontinence, so that's laughing, coughing, sneezing, quick movements. Urge incontinence, which is the need to frequently use the bathroom. You can also get urge incontinence too if you are going through like a lot of life stress as well. So sometimes people will come in and be like, the past 2 months I just cannot control my bladder. You can also have life stressors that increase your nervous system input to the bladder too, and we'll talk about urge incontinence in a second. Prolapse, Dr. Barnum just did a great little thing on that, so that should be clear for you now. And then vaginismus and dyspareunia, pain with intercourse. So vaginismus is pain right when you have penetration of the vaginal wall. Dyspareunia is pain that would be during intercourse and could potentially prevent even completion of intercourse. Those are big, big things that I love to work with because it affects so many people. So types of incontinence. So normal on the far left, bladder, your brain says, hey, bladder contracts, your bladder contracts, the pelvic floor says cool, lets everything out. Stress incontinence, think of stress incontinence as like a balloon, again, that's filled with water, like a water balloon, but you don't have the tie at the bottom, which would be your pelvic floor muscles, and then you punch it. You punch it with like taking a deep breath in, laughing, coughing, any of those puts a lot of pressure inside your abdominals, and that can just kind of punch the wall, so if you're not offsetting that with a good pelvic floor contraction, then you can have loss of urine that way as well. And then the urge incontinence can be that nervous system where it's just kind of overactive. That muscle, that V muscle I was telling you about, that can make you feel like you have to go having too much bladder or too much urine in your bladder, like Dr. Barnum talked about as well. With urge incontinence too, people have triggers. So they will see the front door of their house, they'll hear running water, you all have triggers, right? You know what they are. You can think of them immediately. And so using urge avoidance techniques is going to be huge and we'll get there in a second. I keep getting so excited. Okay, basic techniques for stress incontinence. So the knack technique, or squeeze before you sneeze. So that pelvic floor contraction that you all have mastered by now, anytime that you're going to laugh, cough, sneeze, give that a big squeeze and then do whatever you're going to do. And people think they don't have enough time to do it. You do. You know when you're going to cough, you know when you're going to sneeze enough to squeeze tight, or use your inner thigh muscles, which I don't agree with, but if you have to, the knack technique, so just a quick tight squeeze. Also, do this before you stand up out of your car, up and off of your couch. It really could just become part of your everyday and just get that exercise going. Another big one that we see is when people are lifting their groceries out of their car. You know, they like take their 10 bags out of their car and try to waddle their way into the house, and then people can have complete loss of bladder that way as well. Oops. Urge incontinence. So there's two different ways, primary ways, I should say, to address urge incontinence. So urge avoidance techniques. So you have that trigger, you're washing your dishes, you feel the urge to go, you just went 10 minutes ago, what the heck? So you're going to stop what you're doing, think about something completely different. It's literally mind over matter, a mind game you play with yourself. Not to get too nerdy, but there's 6 feedback loops from your brain to your bladder specifically, 3 of which you have control over, and 3 of which are driven by how full your bladder is and a bunch of other things that you don't have control over. So by using the urge avoidance techniques, you have control over your bladder. So again, change your mind, stop what you're doing, squeeze and relax your pelvic floor a couple times. Try that a couple times, take some deep breaths. If it still doesn't work, then go to the bathroom. But the power of the mind and the body is huge, 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 huge. And then time toileting. So this is a very easy thing to implement tonight. If you are someone that's going to the bathroom every hour, you always have urine in your bladder. Just like you always have oxygen in your body, even if you exhale, there's always going to be some residual left. So as your bladder fills, it hits 3 different sensors that tell your brain essentially how full your bladder is. And so it hits the first sensor, says, hey, I'm filling. Your brain says, cool, keep on with your day. We're a team, we got this. The second one says, get there soon. You say, I'm waiting. That third one, I have to go now. What we find when people are going every 30 minutes to an hour, hour and a half, is that you're getting to that first or second sensor, and you're basically telling your body, like, that's my capacity, that's all I can hold, when really you should be able to hold, 2 whole cups of water, and so you're letting it go. And those sensors just start to think that's normal, so it hits that sensor, it gets really overactivated and hypersensitive, and that your brain just learns, I gotta go now, I gotta go now, I gotta go now. So by pushing it out a little bit longer, or for a course of a week, training it that, hey, I can actually fill for 2 hours and I'll be fine, and 2 hours and I'll be fine, and doing that for a little bit, then you can eventually add 30 minutes to that and make it up to that 3 to 4 hour window. And people will find that you have like a special window, if you will, where you're like, oh, I can make it 3 hours, but I cannot make it 3.5, and that's fine. We just want to get it closer to that 3 hour mark. So starting to go every 2 hours, I just kind of said that generically. That's pretty much where we start about everybody in the clinic. And then do that for a week. If you can do 2 hours and stay continent, no urine loss, then you can add 30 minutes the next week. Do that for a week. And really be diligent about it, too. The other thing, too, is avoiding the just-in-case pees. So I'm going out to lunch, I need to go pee just in case. Or I'm going to go potty, and then I'm going to brush my teeth, and I'm going to go potty one more time just so I don't have to get up in the middle of the night. There's not physically enough urine in your bladder to empty. And so, again, you're just training your bladder. I don't have the capacity to hold it. And your brain says, okay, whatever you tell me is true. So really forcing yourself to lengthen out that time. Okay, back to Kegels. So there's 2 types of Kegels. There's quick flicks. So those are the quick, fast repetition ones. Those are the ones that are with laughing, coughing, sneezing. I have handouts on this too, so it'll give you kind of your exercises, if you will. And then there's long holds. So long holds, you should be able to squeeze and hold your pelvic floor for 10 seconds. That's going to get you more like getting to the bathroom. The quick hold, the quick one isn't going to get you to the bathroom. That's going to get you in a pinch. But the longer holds will let you walk to the bathroom and make it in time without losing your bladder. And then I really want to stress that Kegels might not be the answer. A lot of times people come in and they say, I've been doing Kegels and nothing's helping, but then they also have all this abdominal pain and that kind of stuff. If your muscles in your pelvic floor are already tight to begin with, so let's kind of think down all the way down to the cellular level. If they're already tight to begin with and then you go to contract, they're not like contracting together to stay strong. They're just kind of, and you're not going to get any squeeze. There's going to be nothing there to bind onto to get a good squeeze. And so sometimes we need to lengthen those muscles through stretching or through manual stretching, which is where I would insert a finger vaginally and we can access those muscles easier and kind of work on lengthening them. And a lot of times too, when you have incontinence, people don't even realize that those muscles are short or that they are tender until they're touched very specifically. And they're like, whoa, I had no idea I had a muscle there. But we do a time or two of kind of, again, the stretching and stuff, and you're able to contract properly. The hose can kink off, and then you're not having the bladder loss anymore. Prolapse. So this is back to what Dr. Barnum was talking about, just some views here. So the top left is your bladder. These are not exaggerated photos because they do happen, but it just kind of goes to show what it would look like. The top right would be your rectocele. You feel like you have a bowel movement and you don't get everything out, you can get stool. So we're on the top right now. You can get stool that can kind of collect in that pocket, which is why you would then insert your 2 fingers vaginally so you don't get the pocketing and then everything comes out. Whereas when you don't, you can have the stool there, so you think you're done having a bowel movement, you stand up, you walk around, and then that stool can hit on that. There's a little pressure sensor within your external anal sphincter that tells you have to poop, so that poop can touch that sensor again, and then you feel like you have to go again. But there might not necessarily be enough pressure from above to have that bowel movement, because it's just a little bit, and that leads to the straining, or people can stick their finger, various things up their rectum to try to get their stool out. The bottom left would be your uterus. That would be that stage 4, completely out of your body. And then you can get small intestine too. Okay, so pain with intercourse. This is one I love to talk about because a lot of people don't. Like, you'll talk about with your girlfriends everything else except pain with intercourse. True story, I had 2 best friends I was treating at the same time. And I can't tell you like, oh yeah, I just worked with Barb the other day. But I'm like, did you tell your girlfriend about this? No, I'd never tell her. Okay, so pain with intercourse. So vaginismus is pain before or with penetration. So right at that vaginal opening. Dyspareunia is more pain during intercourse or pain that prevents intercourse. Again, tight muscles, after you have a baby and you have that stitching, that can prevent, again, how that tissue moves with penile, finger, toy penetration. Vaginal dryness. Let's see, different impairments of the skin, so you can get different kind of dermatology things going on too. And physical therapy can help, like we talked about, getting those tissues to move and to lengthen and giving you techniques how to manage at home as well. Use of lubrication. So the idea of lubrication is there's a certain water content in lubrication. And so we want to try to get away from like the KY, the Astroglide, the stuff that's sold in the store, because those have such a high water content that when that enters the vaginal wall, vaginal mucosa just like love water, and so it's just going to take all that water out of the lubrication, essentially leaving you with nothing to work with. So we want to get down towards the right more. So slippery stuff, which is the far right here, and then Sliquid. Both of those can be bought on Amazon. Slippery stuff, we're trying to get into Target. We have a special interest group working with Target Corporate right now to try to get more pelvic female continence supplies into Target, so it's not just the pads and that kind of stuff. So Sliquid or slippery stuff is what you want to be using, because that's going to give you more time behind the use of the lubrication. The other thing I'll mention about using lubrication too is you want to use a lot of it. A lot of times people are like, oh, I'm too young, I don't want to use it, or I don't need it, it's going to cause a myriad of issues. But you want to make sure you're putting it right on the vaginal opening and then either on the finger, the toy, the penis as well, because then it'll just slide easier. You don't want a lot of vaginal friction on those tissues, especially as we age too, because they're already thin. So using that lubrication is just going to help keep things nice and healthy. So, would you benefit from pelvic floor PT? Do you have incontinence throughout the day? Do you feel like you're going to the bathroom all the time? Do you have abdominal pain, pelvic pain, weird hip pain that you just can't get rid of, no matter how much other PT you've tried? Back pain? running to the bathroom a ton, pain with or during intercourse. So a little bit about what we do in PT. So you'd come in, it's just a one-on-one session. Husbands are welcome. Love to educate them as well. And we just discuss kind of what your individual symptoms are. We look at how your abdominals are working, your lower extremities, your legs, your back. And then pending the time we have left, most of the time I like to do an internal vaginal assessment that same day so we can see how those muscles are working and to see if you have those tight muscles that aren't allowing you to get that good contraction and that closing off of the urethra that would lead to bladder loss. And then giving you exercises to work with. Most insurances do require a referral from your provider. There are some insurances that have direct access, which means you can come right to a physical therapist, but most of the time, ask your doctor for a referral. So all in all, Kegels might not be your answer, so if you are a Kegeler and it's just not working for you, that would be a really good sign to come in and get some physical therapy. Changes in your bladder behaviors can make all the difference. Again, going back to those time toileting ideas, the urge avoidance techniques. And then just a reminder that I don't just do bladder control. So if you're having issues with constipation, loss of stool, abdominal pain, any of that I can help you with that as well. This is my other favorite meme of my show. Isn't that great? So true. Any questions for me? Yes.
Does caffeine or alcohol affect
the
urge part of it?
Yeah. So in relation to the diet, so caffeine, citrus products, so orange juice is a huge driver. Artificial sweeteners like the Crystal Lights, the fake sugars, all that kind of stuff. Heavy-based tomato products like one tomato or tomato sauce with your dinner probably isn't going to be the cause, but if it's like a heavy, like in the summertime, if you're like, why in the summer? A lot of that fresh tomato, that kind of stuff. Alcohol and carbonation. So people are like, oh, I drink bubbly water, but I don't drink water. That carbonation still. And the idea of coming to coffee and orange juice, those things are highly acidic, and so it makes your urine really acidic too. So the more acidic your urine is, that bladder lining has a sensor in it too to tell you how acidic or how much pH is the pH of your urine, and that can create the bladder to kind of freak out too. So I use the analogy of like, if you have a paper cut, you're not going to pour salt on it. So if you have bladder issues, don't, put the things in your body that make it mad, and find out what those might be. So if you know you're going to be going out, you're going to go on a vacation, and you know that coffee is a huge driver of your needing to go frequently, maybe you don't have it that one morning, but you can have it other times. So I don't like the idea of like cut it out. I really encourage cutting out orange juice because I've had patients that have just cut that out and their symptoms go away completely. I don't know what it is about orange juice, but so yeah.
So there is
Good
low
question.
acid orange juice. Would that help then?
It might. You could try it. And again, everybody's body is different. And that goes back to kind of the myth too, like I have incontinence, so I don't drink water, because every time I drink water, then I have to pee. Well, actually what that is that's that trigger, right? I talked about you have those triggers. You've trained your body that I drink water, I pee. That's not true. So you get more dehydrated, and the more dehydrated you are, the more acidic your urine becomes, and then your bladder wants to squeeze and empty it because it doesn't like that acidic urine. So trying to dilute it by getting more water intake in your diet as well is going to help a lot. And help with your stool too. So when we think of constipation, so again, your rectum is on the far back side here. If your rectum is filling up with stool and you're not getting it out, it's compressing on all these other organs in here, so when your bladder goes to fill, like that balloon, if it has nowhere to go, then that can create that urgency as well. So a lot of times people say, oh, I don't poop but every 5 days, but that's not why I'm here. We actually address your stools first to get those more normalized so that your bladder has room to fill and empty and live happily ever after. So in those handouts back there, I have just kind of an outline of basically everything we talked about. I outlined the time toileting. There's handouts on the urge avoidance techniques. On the back of one of them is how long to hold the Kegels and kind of what to work towards there. And then on the very back page are like two very basic hip exercises you can do. One sitting and squeezing a pillow. So again, using that inner thigh. Like I don't want you to use your inner thigh while you're doing your Kegels, that getting the strength of that muscle up is going to kind of give that overflow into any weakness that you're having in your pelvic floor. So literally while you're watching TV, squeezing a pillow, super easy. And there's another one where you sit and you push your knees out against like an exercise band. You can even just start moving your legs in and out to get that movement as well. Another big thing I see is after hip replacements, depending on how you have your hip replacement, because they extract some of the muscles away from the hip that help with that movement, that outer movement, and that outer movement is what helps elevate and kind of kink off that hose too. And so if you've had a hip replacement and now you're noticing a bunch of incontinence as well, then we need to work on getting other muscles to help boost the strength of your pelvic floor, because those particular ones aren't given the lending helping hand that they once used to. So, other questions? Yes.
I'm full disclosure, I've had physical therapy for incontinence in the past, and for the stress incontinence.
Okay.
So what I was told was that I needed to learn to relax that muscle. That was sort of like the first step of therapy, was staying still for 20 minutes, relax the muscle, because I was holding it so tight that if I did sneeze, it, you know.
Yep.
But at the time I had a newborn and a toddler, and I just laughed at the thought of relaxing. So anyway, but now they're older and I can do that. But so is that something then you recommend as a sort of first step when you see somebody like me with the stress incontinence?
It really depends on that internal assessment.
Okay.
If my approach has changed now that I have 2 little ones at home, I no longer give out like 12 exercises. I'm like, here's your 2, good luck. I'm with you. But it really depends on the internal assessment. You know, if we're doing the internal assessment and things are really painful, then yeah, we need to work on getting those muscles to relax and to lengthen. Again, going back to that idea, when they're sitting, they're kind of out away from each other, and we really need to get them close so they can give each other a hug to help each other out. So it may be a recommendation, but it really depends. So I've never told anyone to relax for 20 minutes because I can't do that myself. But definitely techniques. A lot of times with the urge incontinence, like I have to go all the time, people, this is a very generalized statement, I don't mean to offend anybody, but they're more rigid with their schedules. You know, they're go, 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 they don't stop, they have high stress in their lives, that kind of stuff. So again, we kind of figure out what those stressors are so that you can just tune into your body and know like, oh, let's take some deep breaths here, because if not, I'm going to have to go to the bathroom during my big meeting coming up or during whatever thing is happening. So more kind of awareness than anything, figuring out what those triggers are for your body. That is a thing. And a lot of times too, I have people do a bladder diary so I can assess, are you drinking too much or are you not? I had a patient one time who was drinking 1.5 gallons of water a day.
Oh my God.
I had to tell them to not drink that much water, you know, and they stopped and it got better. But most of the time it's you need to drink more. They used to say the whole 6 to 8 ounce glasses a day, but now urologists are more saying you want your urine more pale yellow to clear. So they're going more on the color of the urine versus, you know, half your body weight in ounces or how many cups to have per day. Because again, every body is different. The things you're putting in your body is different than your neighbor, all that kind of stuff. So looking and paying attention to getting your urine more pale yellow to clear earlier in the day versus, you know, 8 o'clock at night would be an indicator of how well you're doing with your water intake. So if you're someone you're like, you know, it's not getting there till 5, maybe you do need to drink a little bit more water. But if you're there by lunchtime, you probably are having good water intake during your day. pelvicfloorrehab.com is a good place. So the institute that I've done all my training through, we can go and just put our name there so you can look in your area to see people who have the training. There are different levels of training too. So like pelvic floor 1 is just more of the, I don't want to call it basic because it's not, but more of the like early intro to pelvic floor all the way up through capstone, which is the whole male pelvic floor, constipation, bladder, all that kind of stuff too, which isn't necessarily seen on that. So you can always just call, you know, when you find someone and talk about your symptoms before you go too. I've had a couple patients do like discovery calls and yes, I can help you. I really think you should see an OB first or someone else first.
Doing your Kegels right, are you really supposed to be able to shut off your urine flow and let it start again?
That's hard to, because it's a matter, again, of how your anatomy is set up. I would never do that like as an exercise, and that I kind of say just find your muscles to do that, because then that can lead to the backing up of urine and the frequent bladder infections as well. It is a good sign that they're not super strong. You know, if you can try to squeeze and it slows a little bit but not quite, that can be an indication of them being a little bit weaker, but it's not like the true tell sign of I need therapy or additional support. Anything else? Excellent. All right, well, thanks for coming. Again, there's handouts back here if you want to grab one. I have my contact information on the top, so feel free to call me or set up an appointment. You guys are free to go. You're welcome.